Deborah Parham-Hopson, who's a former colleague of mine at HHS and another person who has been really working incredibly hard for many years in addressing the epidemic. She is the Associate Administrator for HIV/AIDS at the Health Resources and Services Administration, which is part of the U.S. Department of Health and Human Services, and it is the part of the government that operates and oversees the Ryan White Care Act. As you know, the Ryan White Care Act funds medical care, treatment, referrals, and support services for uninsured and underserved people living with HIV disease, and also works with healthcare professionals for training. She also holds the rank of Assistant Surgeon General and Rear Admiral in the Commissioned Corps of the United States. She gets a very nifty uniform for that, and has received many honors, but I think the most important honor is the thanks from a very grateful community who has benefited from her work, and we look forward to your remarks. Thank you for coming.
Thank you for that kind introduction, and good afternoon. I know you've been sitting for a minute, so why don't you just take a 15-second bio break and just stand up, breathe, move around. We don't want DVT in here, so. And while you're doing that, I just want to thank the American Academy of HIV Medicine for hosting this very important forum. You can all sit down when you want. Okay. It's like church, you know. Okay, stand up, sit down. And thank you to the Academy also for inviting me to participate. I will say that I was scheduled to be earlier on the panel, but I had a conflict, so thank you to the Academy and to Dr. Chaw for switching places with me. The challenge with doing that, though, is that as I heard the conversation, I thought, yeah, that was a point I was going to make. Yes, that's a point I was going to make. So it's a bit of a challenge to stand up here and tell you what you already know, but there are some points that I did want to emphasize, and based on some of the questions that I heard in the last session and some of the concerns, I do want to assure you that we in HRSA, working with CMS in particular, are very aware of some of the issues, but it's always great to hear from you who are on the front lines actually out there providing the care. What are those issues that you are seeing and hearing and working with every day as you're trying to provide care to people living with HIV? And as we transition people into the Affordable Care Act, which I agree is a great program. It's going to cover a lot more people with insurance. We understand that insurance doesn't equal access necessarily, but there are lots of good things in the Affordable Care Act, and I'll cover some of those. But one of the things that I keep hearing, and I heard a little bit of it in the previous session, is we talk a lot about outreach, identifying people who are, the whole cascade, identifying people who are HIV positive, linking them to care and retaining them in care. And I'm very concerned that with the little 19% that we've retained in care and gotten virally suppressed, I don't want that number to go even lower, because we now find that people are not transitioning to a new provider. They are dropping out of care. So that's one of the big concerns that I have as we move forward. So working with all of you, we need to figure out how not to make that happen. Now I'll do my prepared remarks that my staff prepared for me. Yes, I do want to talk to you this afternoon about what I was asked to talk to you about, which is what are some of the things that we think that Ryan White providers in particular need to know as we move forward with full implementation of the Affordable Care Act. We know that as recently as November of last year, only 13% of people living with HIV and AIDS in the U.S. had private insurance coverage, and nearly a quarter of people living with HIV and AIDS had no coverage at all. The remaining population of people living with HIV relies on state and federal programs for their HIV care, programs like Medicaid, Medicare, and the Ryan White program. With the recent Supreme Court decision to uphold the Affordable Care Act, at least most of it, we believe that it's imperative for providers, patients, and the HIV/AIDS community to be aware of how these programs and the private insurance market have or will be affected by the Affordable Care Act. I want to review some of the provisions, and if you've already gone over this, please indulge me. But we do know that there are many provisions that will positively affect people living with HIV. No longer will there be lifetime spending caps from insurance companies, and there will be no annual caps beginning in 2014. That's a good thing. Insurance companies, and we've talked about this, I heard it earlier, will no longer be able to deny coverage based on pre-existing conditions such as HIV status for children, and beginning in 2014, the coverage cannot be denied for adults with pre-existing conditions. Insurers cannot rescind coverage for adults or children because of a change in health status. So these are real good things that are part of the Affordable Care Act. In terms of federal state program changes, ADAP, we have heard a lot about the AIDS drug assistance program and the waiting list. The ADAP benefits already count towards the Medicare beneficiaries' true out-of-pocket spending, or TROOP. And that's a huge relief for people living with HIV who are those beneficiaries, because it moves you more quickly through the donut hole. So that's a good thing. That took effect January of 2011, so that's already in place. New insurance coverage options will become available for people living with HIV and Ryan White clients, such as increased access to Medicaid for many states for childless adults up to 133% of poverty, and we certainly heard that discussion in the last panel. The question was asked about the data. We have spent the last few years putting together this wonderful, elaborate, and some of you who are providers who are actually providing the data may disagree, but a wonderful, elaborate client-level data reporting system. And it was put together before the Affordable Care Act with the 133% of poverty. So when you're putting together a data system, sometimes you just don't think 133. You go 0 to 100, 100 to 200, and so forth. So when the Affordable Care Act talked about 133% of poverty, we very quickly knew that even with our new data system, we did not have the data point that we now need. So we need to go back and figure out how we can rejigger, go back through OMB for clearance on our data system so that we can get the information that we need to answer these very big and broad questions. In the meantime, we're doing some estimates. Now back to my points. Some other provisions that will be in the law: Medicare and many private insurance plans are now required to cover recommended preventive services, including HIV screening. And there are a number of things. I think you're very familiar with many of the specifics in the law about how it will affect people with HIV. But one of the things that I wanted to talk about is the interaction of the Affordable Care Act with the Ryan White program. We know that the Ryan White program currently wraps around many of the Medicaid services because by statute, it's the payer of last resort. When you think about it, and I'm going to talk about some of the challenges of that a little later, but when you think about that, even with expanded or not expanded Medicaid, and even with Medicaid being different in different states and in California in different counties, the Ryan White program would still wrap around whatever you have. So the administration is very supportive of continuation of the Ryan White program, even though it needs to be reauthorized in 2013. And there's a backstory of why 2013 as well. And just as the Ryan White program looks different in different states, in different communities, it will continue to look different in different states and different communities. But that's not any different than the way it is now. It continues to be the payer of last resort. It continues to wrap around services that are paid for by other providers. So in Texas, that Keith Rawlings talked about the fact that they have a limited formulary or limited prescriptions that people with HIV can get. Well, the Ryan White program wraps around so that the people living with HIV in Texas do have access to a full range of services that they need. The challenge comes when the Ryan White program, with this flexibility, people are asking, well, will the program still change? And what about the 75%, 25% core service requirement? Well, I will also remind you that there's a waiver. And for those of you who are Part A grantees, those 52 EMAs and transition grant areas, this is a commercial, the application is on the street. And you submit with your application if you want a waiver from that 75%, 25%. So for California, you want more money for case management. Now is the time to think about that and think about how those dollars could be reallocated if under the LIP program, the Low Income Health Program in California, more people, which is the bridge to 2014, more people are already covered for their primary care services. And if you can show that and if you can document that, then there's an opportunity there to ask for a waiver from the 75-25% core services, support services, so that you can spend more money on those support or wraparound services that are so important and perhaps even more important now as we transition patients from one provider perhaps to another provider so that we can keep them in care. It's oftentimes those support services that are necessary for that to happen. One of the other things that we're concerned about is reauthorization. I mentioned that earlier, that the Ryan White program is authorized now through September of 2013. And when we were doing the reauthorization in 2009, people looked forward and said, ooh, 2012, that's going to be the election. We don't want the Ryan White program to get caught up in re-election politics. So let's reauthorize for 4 years. And that's what happened. It was reauthorized through September 30th of 2013. Well, that was September of 2009. Who knew that in March of 2010, we would have the Affordable Care Act with a very critical date of January 2014. So we have a little gap, and we're trying to figure out the bridge of Ryan White from before ACA to after full implementation of ACA. And there are some unknowns, but there are some things that we do know. One of the things that's proven successful is payer of last resort, to help people who are low income, uninsured, or underinsured gain access to high quality and effective HIV care. Well, that presents a problem when you have people who are transitioning, and I'm still learning the ACA myself, but as you're transitioning, there will be a window, kind of like when you have the federal insurance benefits program and you have a re-enrollment period from October to December. Well, what happens if you come and see the Good Doctor Suite in September, and then you're not scheduled for another visit for 6 months, and you don't realize that you have to enroll in something else October through December, and you miss that enrollment period, even though you're eligible for expanded Medicaid services, if perhaps, I'm just using you as an example. After you've told me that they may not expand it in Kansas, my example kind of falls apart, but just go with me here. If that person living with HIV is eligible for expanded Medicaid, Ryan White is the payer of last resort, and the person just chooses to stay with Dr. Donna because they really like her services and don't transition. That's a challenge. What flexibility do we have in the Ryan White program to make sure that we don't do harm by saying, well, you should have enrolled in October through December, you didn't. Ryan White's payer of last resort, so she can no longer be your physician. So we have to work to see what flexibilities we have with payer of last resort, because we know from many examples, California, Massachusetts, that it's not a smooth transition. It's a process. We will be transitioning for, I think, years before everything is settled out. And from what I understand, 2014 is a very critical date with the Affordable Care Act, but there are many dates in the teens all the way out to 2020 with various provisions being implemented in different ways in different years. So as we go through this journey of fuller implementation on January 1, 2014, but continuing with implementation for years to come, what is the role of the Ryan White program? How does it wrap around? What flexibilities do we have? One of the challenges that I have now is that I'm looking to see what flexibilities do we have with current law. For example, we know about the 75 or 25% waiver. We know about payer of last resort, trying to figure out if there's some flexibility there. Because if someone is not eligible to transition, we do know there's payer of last resort, then the Ryan White program can pay. And as people are transitioning into the Affordable Care Act or expanded Medicaid, sometimes it takes a while for their eligibility to catch up, and so can the Ryan White program pay for their medications while they're getting fully certified under Medicaid, because that would be payer of last resort. So we're working with our attorneys now to see what flexibilities we have, because it's not a matter of just trying to adhere to the letter of the law, which we do, but it's always keeping our eye on what is it that we're trying to accomplish. After we've gotten these people into care, gotten them on medications, gotten their viral load suppressed, we want to maintain the high quality of care that they're getting. And so we use the law to help us do that, not to prevent that from happening. I'm going to skip some of this. If you are a Ryan White provider, some of the suggestions that I have, and from the questions that I've heard, you're already doing some of this, is to begin planning to screen clients who may be newly eligible for Medicaid or other coverage available in your state or your county. Also, learn which wraparound services may be needed most in your state based on coverage offered in health exchange plans and Medicaid. One of the other suggestions that I heard, and I'm going to appropriate it for my talk, is don't ask to be invited. Go to find out from your state or in your state when those meetings are, how you get involved in the conversation about the essential health benefits. That's a critical thing that is being discussed now. As you know, there's just broad guidelines from the federal government, but at the state level is when people are choosing those benchmark plans. You need to make sure that the plans that are chosen are adequate for the people and the patients and the clients that you serve. Learn I already talked about the essential health benefits. Ensure that your provider team is informed about the Affordable Care Act changes that may affect your patients. Healthcare.gov is another website that is a website sponsored by, ASPA, in the Office of Healthcare Reform in the Department of Health and Human Services. It has a lot of information on it. Again, it's healthcare.gov, and it's information for providers as well as patients. So we encourage you to not only be familiar with the law, but continue to follow those discussions. There's lots of ways you can get information, the FAP conversations that Donna mentioned earlier. But one of the things, and I want to end with this, is that realize that you are not alone. There are many things that we in HRSA and the HIV/AIDS Bureau are doing. We, too, are working to understand the impact of the Affordable Care Act on HRSA-funded programs and the people that those programs serve. So certainly the Ryan White program, but also the Community Health Centers program, which received significant expansion under the Affordable Care Act, the maternal and child health programs, the health professions program, education programs, rural health. There are many provisions in the Affordable Care Act that affect all of those safety net programs that we manage in HRSA. We are committed to making information available to you. So I was listening to hear what are some of those questions that you still have. And I appreciate Jeff saying that, we're not going to serve everything up to you on a silver platter, but if there are some big, broad things that you need from HRSA or some different policies or questions that you have, information that you need, then I invite you to certainly be in contact with us on what information we need to get out to make it easier for you to do the work that you do. Specific to HAB, I will say that we learned a lot of lessons from our experience with the California LIP program, the Low Income Health Program. We learned about transitioning patients and the challenge of making sure that we don't lose patients to care. We learned that changes may not be statewide, but vary by county or jurisdiction. We learned that it's really important that the networks have the appropriate providers so that we don't have male patients being referred to the gynecologist for their HIV care. We learned about payer of last resort, and we need to have some flexibility there. Based on these lessons, we are taking a hard look at what flexibilities we have under the current law, and we are committed to issuing policy about that. We also realize that some changes are necessary to the Ryan White statute, which is up for reauthorization in 2013. So the timing may not be the best, but we are looking at reauthorization to actually build more flexibility into the Ryan White program. We're gathering input from you and other stakeholders about changes in the Ryan White law. I just concluded 4 listening sessions, and I know that some of you were on those calls, and I heard a lot from people living with HIV, from Ryan White providers, other stakeholders, giving us some information about the challenges in their states with the Affordable Care Act. And I will say that I was listening for what are some of the ideas people have about changes for the Ryan White law. And I will say that most of what I heard was questions about what will the Ryan White program look like after the Affordable Care Act is fully implemented? Will social services still be provided? Housing and transportation, those support services are so critical. Will they continue? What about services that are not covered under Medicaid, like oral health? So there were a number of questions that people had that certainly gave me pause and helps inform me of what other information people do need. I do know that there are still some unknowns, and I understand you heard some of those from Dr. Cha. So we're still working very closely with CMS. Our relationship with CMS has never been so close. So this is a good thing. They're learning our language. We are learning theirs. So, and I know some of you might be saying, you know, I'm a clinician. I just want to take care of my patients. That's why I got into this field. We are committed to working with you as you continue to do what you do best, which is to move heaven and earth to provide a full range of services for your patients. Yes, the healthcare landscape has changed and it continues to change. But I would argue that HIV also changed the healthcare landscape, but you rose to the challenge and you helped build a system of care for people living with HIV and AIDS that is unrivaled in the world, and for that you should be congratulated. So I know that you're up for this challenge as well. This week, many of your successes will be showcased. So I thank you for what you continue to do, and I look forward to continuing our partnership as we turn the tide together. Thank you very much. You want to stay here or you can stay here? Okay.
Thank you very much. Questions? A couple of questions from the audience? Yes.
Dr. Hopson, I'm from South Carolina, one of the states whose governor doesn't want to expand Medicaid. So and I work in an HIV-only clinic. And a couple of questions I have for you. How secure is the 340B funding for Ryan White clinics? I guess one of our concerns in our clinic is we're not an FQHC, but the 340B funding is how we pay our bills and to supplement our Ryan White funding.
Yeah, right now the 340B program is secure. I mean, there's certainly always a lot of questions about it, and there are certain sectors that don't really like this 340B program, but right now it is secure, and we do encourage our Ryan White providers to take full advantage of that.
And do you think that will still be the case once the ACA is fully implemented?
I don't know.
You don't know. Okay. Do you, and you may have the I don't know answer to this too, do you think the Ryan White only, the HIV only clinics are sustainable?
That's a great question. And I would ask some of the others who are here in the audience to help with that question. What's your crystal ball telling you?
That was one of the problems that I brought out before you arrived here.
Oh.
That I quit a Ryan White clinic because we weren't able to, and I went back to private practice trying to transition my clients into a more of a managed care and private setting because we weren't able to provide the primary care services because of the restrictions of the Ryan White clinics and the cut in monies. They ended up denying a lot of laboratory services, primary care labs, and telling them to find primary care providers, where originally the whole concept of the Ryan White Clinic was one-stop shopping, comprehensive care type services. And we reversed that by starting to refragment all these issues and farming out primary care to primary care providers for heart services, cardiac medications, non-HIV related medications, but what we're finding now that all these medications are related to chronic primary care HIV. And so therein lies our conundrum or crux of the problem. How can we still make these Ryan White services, wraparound services, still relevant in helping what you just described? And how can we keep that group communicating with primary care services and get these people the comprehensive care that they're going to need because of the aging and the chronicity now that we are dealing with HIV?
Yeah. What I would say is that when you look at the Affordable Care Act, what systems of care were expanded? It wasn't the Ryan White program, it was the community health center, the primary care clinics. So if I had to do prognostication about what I think would happen, that's what I'm seeing happening is expansion of those clinics. So what I have tried to do is to encourage, and I don't want to carry this analogy too far, but to encourage Ryan White only providers to marry a community health center in some kind of way, so that community health centers who serve all comers, regardless of ability to pay, can provide some of those primary care services, and the Ryan White dollars can pay for those HIV-specific services. I know that that's not a panacea, and I know that that doesn't work in all communities. But when I look at where the expansion, as I said, where the expansion has happened, at least in the safety net programs, it has been in those community health centers. So I heard the gentleman from Seattle talk about the telehealth program. What we said in HRSA and in the HIV/AIDS Bureau, that if that's the place where the expansion is happening and more people living with HIV will go to health centers, how do we bring them on board and bring them up to speed in terms of being able to provide high-quality, competent HIV care? And the telehealth program is one of the ways of spreading the expertise that we have garnered in the Ryan White program beyond the borders of the Ryan White program. Certainly the AIDS education and training centers as well can also provide training for people who are working in community health centers, not in Ryan White specific centers.
But that in and of itself, in its own way, is fragmenting the care once again, because the Ryan White centers are being forced to send these people to these community health clinics because they don't have enough funds to help with those wraparound services. So how can you communicate to these clinics that they are still partly responsible or can help in some way when the qualified health care clinics or the new managed care plans fall short and they need primary care medicines in addition to their Ryan White medicines and Ryan White focused health care, how they can actually be flexible with the payer of last resort and still help provide some of these primary care issues.
Yeah, I hear you. It's not an answer that I can just give you the panacea and give you the answer today. It's certainly those questions and challenges that we continue to face, and I will continue to work with you to make sure that we are able to provide the full range of services for people living with HIV wherever they end up getting their care. Next question.
Sir?
Yes. My name's Joey Wen. I'm from Fort Lauderdale, Florida. First, let me say it's refreshing to see so many people from the South being able to be here and convey our stories and our challenges in providing HIV care in the South. I have two difficult issues, and my question is how you're intending to move forward in terms of finding solutions. The first one is about funding formula for states in the South that know that they're not going to expand Medicaid. I think you've heard from a variety of us from different states, and being from Florida, we have an excellent relationship with our Medicaid office. We have elected officials that aren't going anywhere. They're elected until their term limits. They're very safe in what they say and what they do because of who votes for them and how things turn out. So we feel there's an opportunity with reauthorization to ensure that we don't get penalized for those states that don't do Medicaid expansion, because either limited state budgets, there are no state income taxes, there are no mechanisms for us to have money. It's not that there's lots of money and they're determined not to give it to us. It's simply there is no money. And so how do you not penalize those states that don't have Medicaid expansion, that don't have all kinds of other payer sources to enrich their programs, because there's a huge disparity for us in the South. We don't have basic access to medication and medical care for many people, and yet we see other states that have great state support and Cadillac model healthcare systems for people living with HIV. We look at this reauthorization during Affordable Care Act and Medicaid expansion as a potential to harm us even further and have a greater disparity. I know that's a difficult issue, but we're looking to how will you look for information and solutions from the South in particular in this kind of larger construct that's going to penalize people living with HIV in the South. And no, we don't want to move to other states. That's not an option.
No, I wasn't going to say that. Realizing that there are real differences, geographic differences. The very first listening session we had focused on regions 4 and 6, which are those states in the South. There is still opportunity to provide written comments, so I urge you to go to our website and provide your comments that way. That way we have a list of all of the issues that have been raised from people around the country about and ideas that people have as we move towards a different solution in a reauthorized Ryan White program. So I heard you talk about funding formulas. Those are statutorily driven. So in order to change those, we would have to change statute. So it would help if we had some written comment from people who are living in these various jurisdictions to say, this is what we're seeing in our jurisdiction, this is what we're seeing in our state, in our community. And because of the various circumstances, we need some different formulas in the Ryan White program. But I will say all of the formulas are statutorily driven. So it does take an act of Congress to change those.
And secondly, what are the options to have demonstration models like CMS with their Centers for Medicaid, Medicare Innovation, to have something very different exist within the CARE Act itself?
Yeah, we only have the SPINS program for demonstration programs within the Ryan White law. Again, our law, as you know, is very prescriptive. You must do this with Part A, this with Part B, and there's not a lot of flexibility there. So again, the SPINS program, the Special Projects of National Significance, is the only program and the only dollars dedicated for those kind of innovative ways of looking at care and then evaluating those models that work and then integrating those into the other Ryan White programs.
Thank you.
You're welcome.
I'm David Schmidt again, formerly of Miami, and I'm moving a little further south in Fort Lauderdale. Ever since the early 90s, practices with large numbers of HIV patients, primary care, have never been able to be adequately funded. And there's been a sort of tacit but integral private-public partnership between the pharmaceutical industries that use our groups of patients as a basis for dubiously scientific but clearly commercially valuable studies. And it is the revenues from those studies which have kept a number of the South Florida practices afloat. We're talking practices with 2,000 to 3,000 HIV positive patients doing primary care. Without those, right now, those practices would go under. New alliances have been made with other private entities. But in no time in my 20-odd years of experience in that area have a practice devoted to primary care HIV in which we posit ourselves as the direct caregivers to the patients and the consultants work for us so that we can avoid the problems of multiple opinions and unnecessary conflicting medication by being the only person who gives advice. Without the participation of somewhat self-serving but as I say, valuable pharmaceutical participation, none of those practices could have survived. And I think that trying to understand primary care, HIV primary care in the absence of that off-the-books sort of contribution is dangerous because that really has kept several thousand HIV patients in primary care in that area.
Hi, I'm Carol Treston with AIDS Alliance and the AIDS Institute. I'm actually going to repeat a question from earlier. I don't think you were here for it. And that's about pathways for Ryan White providers to become medical homes. and including technical assistance that's required, and are there any kind of, no, this was your question, so if there, and of course the medical home means enhanced Medicaid and Medicare reimbursement. So if you can talk a little bit about pathways to that for Ryan White providers and
I can
technical
talk
assistance that may be
very little bit
provided.
about it. We do have a technical assistance contract. Harold or Michelle, do you remember who that's with? I can't remember. But we do have technical assistance with a, it's a cooperative agreement. I just can't remember who it's with, but I can certainly get that information to you about Ryan White programs that want to transition to become medical homes, because we do know about the enhanced rates, and so we're trying to figure out what are those opportunities that are available under the Affordable Care Act that would benefit the Ryan White program. So we do have technical assistance available. We're very aware of it. I just can't remember who it's with right now.
Well, let me thank Dr. Hopson and also just thank her for all that she does for us